Hello, good morning, good afternoon, good evening from wherever you're joining around the globe. My name is Chukokafo. I'm going to be teaching you on the topic anatomical variations in the brachial plexus. First of all, you might want to ask, why is this topic relevant to you as a potential healthcare professional? But I want you to imagine a bit that you are a surgeon, preparing for a complex procedure involving the shoulder, for example. And then you have performed the surgery countless times. But today something feels different. You encountered an unusual nerve pathway unexpectedly. And then this is different from your experience, different from what you've studied. What do you think you would do? We normally say experience is the best teacher, and you would not blame the surgeon when he goes on to ignore that pathway because experiences over the years have actually impacted the evidence that they bear in the decision that they make. So this is an example of anatomical variation and how it can actually affect decisions, and also influence medical outcome. Have you also wondered why some patients react differently to standard medical procedures, or why even certain conditions are more challenging to diagnose in some individuals? The answer often lies in the unique variations that we have in different persons. So when we understand these variations, it will help us as healthcare professionals to be able to make clinical decisions, diagnoses, and be able to understand how people will vary and will be able to give a good patient care. So today in this lecture, we're going to be basically having an overview of the basic anatomy of the brachial plexus. We're going to discuss the common and the rare variations, and we're going to also examine the clinical implications of these variations using a few of the live case studies. And then we'll also have some level of interactive quiz to be able to reinforce key concepts. So by the end of the class, I'm sure we'll be able to approach uh, understand the different approaches that one can take and how one can be able to make use of the knowledge of anatomical variations in making clinical decisions. So let me start by looking at the classical anatomy of the brachial plexus just as a refresher. Brachial plexus is a network of nerves. I want to say a finely connected network of nerves that are usually come from the spinal nerves, the ventral root of the spinal nerves. You have five of them in the classical concept of the brachial plexus from C5, C6, C7, C8, and T1. So these five roots are, lead the formation of the brachial plexus. And these roots go on to form three trunks: the superior trunk, the middle trunk, and the inferior trunk, as you can see in the picture right here. So the first two nerves, C5 and C6, gets to form the superior trunk. C7 continues as middle trunk, while C8 and T1 gets to form the inferior trunk. Each of these trunks form an anterior and a posterior divisions, anterior and posterior divisions, as you can see right here, superior having the anterior and posterior, middle having its own anterior and posterior, and also the inferior dividing into anterior and posterior divisions. And then these divisions go on to form the cords. So you have three trunks and you have three cords. You have six divisions, two from each of the trunks, and then you have initially, as I've said, five roots. I want you to take note of the number. In that sense, it starts with a 5 and is going to end with a 5. Starts with 5 roots and is going to end with 5 terminal branches. And then you have 3 trunks and then you have 3 cords. Very important. Now, at the level of the trunk, you're going to see after the formation of the anterior and the posterior divisions, note that for the trunks, the divisions to form the cords, all the posterior divisions, merge together to form the posterior cord. It will help you to understand how these things are formed. Posteriors lead to posterior. All the posterior divisions form the posterior cord. Then the anterior division of the superior and the middle trunk forms the lateral cord, while the anterior division of the inferior cord forms the medial cord. And then these cords, from their names, lateral, posterior, and medial cord, shows the relationship they have with the axillary artery and the position of their position with the axillary artery as they are found in the axilla. That brings us to the positioning of these of the network of the brachial plexus. The root itself comes from the intervertebral foramina and is usually at the level of the root of the neck. And then at the level of the trunk, we are going to find them when you are dissecting. You're going to find them exactly at the posterior triangle of the neck, especially at the interscaling groove where you have just above the clavicle. You're going to find all the three trunks. And then the divisions are found just behind the clavicle exactly at the cervical axillary canal. That is where you're going to find the 6 divisions. So if you're trying to detect or to find out or to study in the cadaveric the cadaver, the classical nature of the brachial plexus, you're going to follow this map. From the root of the neck, you're going to proceed into the posterior triangle of the neck, and then you're going to get into the behind the clavicle at the cervical axillary canal, where you find the divisions, and then you're going to find the cords well situated within the axilla, and you find them just wrapped around the axillary artery. These cords go on to form the 5 terminal branches. You have the medial part of the lateral cord and the medial part of the medial cord forming the medial nerve. And then you have the posterior cord forming 2 nerves, axillary nerve and the radial nerve. And then you have the anterior part of the lateral cord forming the musculocutaneous nerve and also the posterior part of the medial cord forming the ulnar nerve. And this leads to the 5 terminal branches. Now we get onto the pre-terminal branches of the brachial plexus. There are also branches that go off from the different parts of the brachial plexus, from the roots, from the trunk, from the 3 cords. But it's important to note at this stage that for the classical nature of the brachial plexus, there is no branch coming off from the divisions. The 6 divisions have no existing pre-terminal branches from the classical nature of the brachial plexus. So we can appreciate here the branches that come off from the roots. You can have the dorsoscapular nerve, C5, long thoracic nerve, branches to the longus colli and scalene muscles, and you have suprascapular nerve and nerve to subclavius coming up from the trunk. And then for the cords, the lateral cord gives off a lateral pectoral nerve branch, and while the medial cord gives off the medial part of the pectoral nerve and also gives off the medial antebrachial and brachial cutaneous nerves as well. And for posterior cords, you have the rhacodistal nerve, very popular for its role in the latissimus dorsi, and also gives off the upper subscapular nerve and the lower subscapular nerve that supply the subscapularis muscle and the cerebrospinal as well. So these pre-terminal branches go further deep into the upper limb and make specific function and control of the entire muscles within the upper limb. So I've given this diagram for you to be able to appreciate. As you can see on the screen, you can see the dorsoscapular nerve coming right here off from the root. You can see it from the C5 root coming off, and then you can see the long thoracic nerve coming off. You can see the long thoracic nerve coming off from C5 down to the C7 to down to where it's going to supply eventually the serratus anterior muscle. Okay, you can also appreciate here that, as I said before, there is no branch coming up from division, as you can see here. But right there before the divisions, you're going to appreciate the trunks, and you're going to appreciate the suprascapular nerve that you're going to find right at the suprascapular notch. That is a typical marker that you will use to note this particular nerve when you are doing dissection. It's going to be found at the suprascapular nerve, where it's going to supply the infraspinatus and the supraspinatus as well. And then you're going to see another branch, nerve to subclavius branch, just right there at the C5 to 6 that supplies the subclavius muscle. And then again, you get to the cords, you're going to see lateral pectoral nerve, you're going to see the medial pectoral nerve, you're going to see the antebrachial and brachial cutaneous nerves as well. Then the other picture is just to show you the nerve to the longus colli and the scalene muscles. That is a branch of the roots. Now to take a look at the variations. What actually gets to vary? We have majorly about 17% of the brachial plexus, usually come with a prefixed nature. This is based on the research. These can vary, but this is based on an extensive cadaveric finding that show that just about 70% are usually present with prefixed models, and postfixed are usually rare compared to the prefix. You have them around average of 7%. Now, what do we mean by prefixed? For the fact that you have 5 roots stemming from C5 to T1, when there is a shift upwards from C5 moving up to C4, we are saying there are contributions from the fibers above that particular classical root of the brachial plexus. So we say they are prefixed brachial plexus. So when when the contributions are coming below the C5, coming from C6 downwards and even extending up to T2 sometimes, we say that they are postfixed. So you can see this diagram to show prefixed, showing contributions of fibers from C4, and then you can see on the other hand the postfixed brachial plexus showing contributions from the T2. And sometimes you can also have postfixed brachial plexus without even a T2 contribution at all. And then we have variations across the different branching patterns, how these branches and how the fiber contributions are made, and a particular nerve, what route actually sends out each fiber to make that particular contribution. So we're going to be seeing this in a while. Okay, this is a table to show a summation of the entire configuration, possible configuration that may be found across different human beings, based on a study of Desai et al. 2017. You can appreciate the fact that the first 3 A, B, and C configurations are basically prefixed. Like I noted before, that you have more of variations as prefixed than we have as postfixed. So the prefix, the A, the B, and the C are prefixed, and most of the variations actually are just little changes or little variation from these 3 classical configurations. The first configuration, the configuration A, is a prefixed that has a contribution of C4 to C7, and then also having C7 to T1 as well, with a contribution of a branch from the medial trunk. And then the B is also prefixed. You're having contribution from C4 as well up to T1. The C is also prefixed, contribution above the classical, which is above C5, from C4 and also down to T1. Now, as you go from the D to the E to the F, you begin to see variations of this prefix model. The D is a variation, a little variation of the A configuration, just having a contribution. Instead of being prefixed like the A, it is starting from the classical variation C5 to T1, while the E is a little a moderation of the configuration B, not prefixed as well, but starting from C5 to T1 as well. What you need to note is that there is no contribution of C8, for example, in the configuration of D, the configuration D. That makes it different from the classical model. It has the same root C5, C6, C7, but lacks the contribution from C8, which is not the same with the classical. Now the E has the same thing, C5 to T1 as well, but then you are having the lateral chord to have C5 to C7, and then you have the medial chord varying, to with the classical model having C8 to T1. So you have the configuration F showing something similar to the E, but whole of the C5 does not enter the plexus at all. And then you have the lateral chord giving off from the C5 the C5 spinal root to C7, while the medial chord comes from the C8 to T1. And then the G configuration, similar to C, but not prefixed as well, and not also postfixed, because this is a model that actually showcased majority having prefixed model. And because you have postfixed models, sometimes you have postfixed not showing any contribution of T2 at all, and they are rarely seen to contribute in most of the variations that has been identified. Now let's take a look at the variations across the different, sections of the brachial plexus to appreciate these variations a little bit more. Now let's start with the trunk. Now we can see that the ventral rami of C5 and C6 and the superior trunk are classically found in the interscaling groove. They are classically found to be there, but sometimes they can instead pass through the anterior muscles themselves, or sometimes anterior to it, and this is usually seen around 25%, of the variations. And again, we can also see that an inferior trunk may not form sometimes, and sometimes you also have the absence of the upper trunk, though that we have more of the absence of the inferior trunk compared to having the absence of the upper trunk. And sometimes we also have the presence of an accessory phrenic nerve. Phrenic nerve is the nerve that gives major supply to diaphragm, and sometimes we have an accessory phrenic nerve which normally runs together with a nerve to subclavius, and this is actually a common variation that we find in about 75% of individuals. So that's massive. Now, you also have sometimes the phrenic nerve itself arising entirely from the brachial plexus rather than from its initial origin. So in the case where all the nerve roots and trunks are not found to pass between the anterior and medial scaling muscles on ultrasound, whether you're doing nerve blocking or you're performing any particular procedure, the interscaling block can successfully be completed by injecting the anesthetic into the interscalene groove, as well as in the areas that are adjacent to that particular nerve of focus. So when you found out that there is these variations, it means that you must make sure that injections of a particular anesthesia or particular procedure will also consider these variations in the treatment plan. Now let's look at what happens in division. Remember, I noted that divisions in the classical model do not have any preterminal branches, but now we can see that in the variations you can have usually presence of variations within the divisions. What normally happens is that the anterior divisions of the medial trunk is usually associated with a lot of variations. In fact, majority out of 85% of variations usually show this. And sometimes you see them connect with the medial cord, the lateral cord. Sometimes they even connect to the both of them at the same time. And sometimes the lateral cord themselves are formed by it. Sometimes too, the anterior division of the medial trunk gives rise to the lateral root of the median nerve with no connection to lateral cord at all. So it can connect to medial cord, it can connect to lateral cord, or it can just run its course and even form the lateral cord itself. So this is a major notable variation that happens at the level of the divisions. Now let's take a look at the cords. What happens to the cords? You can see I've made a table to be able to highlight the original source of each of the terminal nerves, and then look at the possible variations that will emerge. But let me also note that sometimes we have the presence of a single cord. So rather than having three cords, it's possible to have, for example, lateral cord alone forming. You have possibilities of having the medial cord alone forming, though it is not uncommon for the posterior cord not to form, in which case the divisions diverge to directly give rise to the branches and the terminal nerves. Normally, you see these three cords actually encircling the axillary artery like I've explained before, but in some cases all of them get to lie lateral to the axillary artery. And then clinically, if this anatomical variation is visualized prior to any block, for example, the anesthetist could insert the needle just lateral to the axillary artery and must entirely avoid the artery in that particular case. So you can appreciate from this table the lateral pectoral nerve, which is a terminal branch of the lateral cord. Sometimes you have it originating from the anterior divisions of the superior trunk and the middle trunk. Same for middle pectoral nerve. You also have it sometimes coming up from the anterior division of the middle trunk, just like I explained in the former slide. Then you also have the suprascapular nerve that comes normally from the superior trunk. Sometimes you have it coming from the posterior division of the superior trunk. And then you have the thoracodorsal and the upper subscapular, which comes from the posterior cord, and also the lower subscapular coming from the posterior trunk. Sometimes there are variations that are related with changes that could come from either axillary artery for upper subscapular or the thoracodorsal nerve for lower subscapular. Sometimes you also have the axillary nerve also giving off the lower subscapular nerve as well. But for the posterior, for the thoracodorsal nerve, you have axillary or the radial nerve giving off that branch as a part of the variation. And then you have the inferior trunk contributing to variations that we see sometimes in the formation of the medial brachial and antibranchial cutaneous nerves. So instead of coming from the classical medial cords, you see these nerves emerging from the inferior trunk. Now let's look at variations at the level of the axilla. Remember, at the level of the axilla, you're going to appreciate the cords appearing, and then this cause leading to the formation of the five classical terminal branches. But you're going to appreciate how these branches form in a kind of a circular manner, or in a clockwise manner, so to say. You're going to have them align themselves in that order from musculocutaneous, to ulnar, to median, to ulnar, and also to the radial nerve surrounding the median nerve. So you can appreciate that from this picture. You can see sometimes you have, which is one of the majorities, about 67% of variations usually have the presence of musculocutaneous nerve actually varying off, off that circle grid where they surround the median nerve, and situates itself separately and outside that circle. So you can see the different variations, and it's usually about the positioning of the musculocutaneous nerve. So in some case, you are going to find out that even the musculocutaneous nerve actually fuses with the median nerve, as you can see in this particular picture. You can appreciate it here. You can see that fusion being done here. You can also appreciate something that looks like a fusion here. So in that case, there is potentially no need for an additional anesthetic injection, since the target nerve, will also be able to be blocked, by the same procedure. So, but when it's in the case where the musculoskeletal nerve does not lie in its classical location, ultrasound guidance should be able to locate the aberrant nerve so that you'll be able to consider the location and be able to place that anesthetic in that particular location. So these variations are worthy of note to be able to know the possibilities, especially in the case of administering anesthesia. Now, I want you to reflect on what could be the implications of the anatomical variations of the brachial plexus. What could that mean? What could that show us? What can we see? Now looking at that, I want you to just take a moment to share your thoughts before we continue. Just pause this lecture and then let me know, what you think in 2 words, in 2 lines. Just say what could be the implications, of anatomical variations of the brachial. I'm giving you 30 seconds to do that, and then we continue out with the lecture. Okay, now having I'm assuming that you have been able to try to think about what the implications could be, but I've also been able to curate this and see how this aligns with your thoughts. Now, you can see the impact, as I've tried to explain, during the course of the lecture, the impact that, these variations could make in our clinical decisions. For example, there could be unexpected nerve pathways, during surgical cases, and this could lead to complications, and sometimes there could be nerve injuries as a result of, lack of knowledge of this. Sometimes finding out this information could lead to modifying surgical approaches. And again, you can also have anesthetic challenges, especially when administering anesthesia. And there could be complications in regional anesthesia. Sometimes you see people having different kinds of responses, partial blockade, due to presence of anatomical variations. And again, there are usually misdiagnoses. Sometimes new nerves or emergence of variations are even being seen as nerve tumors. They are being mistaken to be nerve tumors, and this could lead to misdiagnosis and imaging interpretations. Of course, in rehabilitation models, you also see that prognosis, this determines the prognosis, because when variations come off from a particular nerve root instead of another nerve root, that could also lead to the level of time needed to be able to manage such a patient because of the nerve pathway that is involved. So this could influence the different kinds of recovery pattern and the physical therapy and management pattern that one would follow. Of course, once we talk about the nerve variations, we expect almost likely that there will also be vascular considerations. There could be vascular anomalies, and these vascular anomalies also could lead to different kinds of risk, especially during surgeries as well. In pain management, we've been able to highlight that it helps us to, especially when we are managing, pain, helps us to specifically target pain because we understand the pathways and we can actually trace our anesthetic plan towards that particular pathway. Now, let's appreciate this case study and use that to reflect more on the implications of these variations as future healthcare practitioners. And this is a scenario of a patient undergoing shoulder surgery who experiences inadequate anesthesia despite a correctly performed supraclavicular block. Upon review, a variation in the nerve distribution is identified, explaining the incomplete block. And then, of course, adjustments in technique or additional blocks are normally required to be able to achieve complete anesthesia. So there was a correctly performed block, but this did not yield any results. The patient still experiences inadequate anesthesia. So this is a classical example of what a lack of knowledge of variations could do in clinical practice. Another case study, a patient present with symptoms of thoracic outlet syndrome, of course, where you have, pains, numbness, weakness in the upper limb that, could be untraced. That imaging gets to reveal an anomalous rib causing compression of an atypical plexus branch. And normally we have this usually from the cervical rib, for example. And then surgical decompression is planned with careful consideration to be able to note that particular variation and to relieve symptoms. Now, another case study, a patient develops unexpected motor deficit after a clavicle fracture repair. And intraoperative findings of an unusual brachial plexus branch pattern explains this particular nerve injury. And early identification of this also will be able to help with the prognosis for that particular recovery. Now, how do we summarize all of this? The first thing is that we need to note that anatomical variation of the brachial plexus is common and can influence medical outcomes. We also need to understand that a nerve stimulation is considered a blind technique, and hence the clinician will not be aware of the underlying anatomical variations, and sometimes it could lead to several misdiagnoses and mismanagement of patients. Ultrasound, in contrast, actually enables the visualization of these nerves and surrounding structures around them, but its use is also dependent on the operator's knowledge of the relevant anatomy. So ultrasound has also shown to improve the success rate of these blocks in patients with anatomical variation. So it's important to be guided, but beyond being guided, it's most important to have this knowledge to help practice. So before I say thank you for listening, I would like you to access through this Google link. You're going to access additional lecture notes. I've added more clinical case studies. I've also added more implications of variations, especially with the brachial plexus. And I've also curated a detailed video on brachial plexus to be able to understand the basics, and then a summarized video as well, just within 1 minute, on brachial plexus, to be able to have the points together. So these are some of the study points that you need to reflect on. And I have a personal self-based online assessment that will help you to check out, your understanding of this particular topic, and I do hope you'll be able to complete them. So once you access this link, the Google link, you can see gives you a document that has all this information, as you can see on my screen. So I also have some recommended tests for you to read, and I'll also be happy to discuss further. I'll also give some time for you to consult if you have any questions, anything that is not clear, or any clashes across different texts that you want to talk about. I'll have my email open, and of course I'll be able to reach out to you within at least 2 working days to answer your questions. Sometimes if I need a meeting, I can actually get to arrange them as well. So this flashcard has been quite useful, so I'm also recommending that. Is the Netta's Anatomy flashcards that also help you to understand some of this, especially the basics of brachial plexus. So thank you very much for listening.